Yes. Good evening, everyone. Dr. Muyanga, please confirm that you can hear me and I'm loud and clear.
Yes, Dr. Katamba, I can hear you very well.
And thank you very much. Yes, good evening once again. I'm saying good evening because I assume majority of the attendees here today are within this time zone where it is evening at this moment. Welcome to the final day of our moratorium educational series, and we are looking at Alzheimer's disease. Today we are closing this series with the management principles of Alzheimer's disease. Just to recap, yesterday we looked at the neurobiology, and Dr. Muyanga took us through a lot of things. He simplified so many things that would look rather intricate. So he told us about the risk factors for Alzheimer's disease, the modifiable risk factors like high alcohol intake, hypertension, physical inactivity, low education. I mean, you can always get educated at any time. And then the non-modifiable risk factors like the family history, the age, then the genetic component where he talked about the gene mutations in the ApoE4 gene, and then the protective ApoE2, then as well as the gene mutations in genes like the presenilin 1, presenilin 2, and the amyloid precursor protein gene. From here, Dr. Muyanga showed us how the neuronal damage actually happens in structures like the brain cortex and the hippocampus, the structures which are really the reason that we see the symptoms that we observe in individuals with Alzheimer's disease. And he took us through the amyloid beta protein, the tau tangles, the neuroinflammation, how all these can either individually or together contribute to the symptomatology that we see. Today, we are closing by looking at the management principles. We are not just going to give the medication that so in someone with Alzheimer's disease, you can give something like this, it might help. No, we are following the biopsychosocial model. And through this biopsychosocial model, Dr. Muyanga is going to tell us, enlighten us on what exactly should be done for individuals with Alzheimer's disease based on their symptoms and the stage at which they come in, as well as the direct pathology that is happening. And then at the end, we shall have a poll where questions shall be posted a poll will be posted, and then questions shall be answered. These will be simple questions from the information that we have actually accumulated over the week. Allow me to invite Dr. Muyanga without wasting any more time to take us through this day. Dr. Muyanga, you're welcome.
Thank you so much, Dr. Katama, for that introduction. Kindly confirm that I'm audible before I kick right in.
Yes, please, you are audible. Please proceed.
Thank you so much. Good evening, ladies and gentlemen. It is a pleasure having you this evening. We are always grateful for the time you spare to be with us, and certainly we believe that whatever you get from here will make you or makes you a better clinician out there. So it's very important, before we talk about treatment, for me to remind you about the basic symptoms that characterize Alzheimer's disease. And this is because, as we shall later realize, Alzheimer's disease management, especially in third world countries such as Uganda, but even in many so-called second world countries or developing countries, management of Alzheimer's by and large is mostly based on symptoms that the person is presenting with. So right from yesterday, I averred that Alzheimer's disease is a progressive condition that slowly takes away one's memory, comes for the independence, and eventually it wreaks havoc with one's ability to function normally daily. And we see this in three main ways. First, the cognitive changes with memory loss, disorientation, language difficulties, and other challenges. And after that, functional decline sets in, where even simple daily tasks such as dressing, handling money, and personal hygiene become hard over time. After that, we have neuropsychiatric symptoms, which include mood changes, agitation, aggression, and wandering. And the treatment, ladies and gentlemen, starts with us understanding all these layers together. So when we talk about treating Alzheimer's disease medically, as I've already said, the reality is that most of what we have today is symptomatic what? Treatment, meaning that our medications focus more on easing the effects of the disease rather than curing it. So these drugs help the brain to function a little better. They support memory, thinking, and someone can go on to dispense of their daily activities. They also help in reducing distressing symptoms such as agitation, sleep problems. So even without a cure yet, we are still actually meaningfully improving comfort, dignity, and quality of life of people with Alzheimer's. Now, when we talk about disease-modifying treatment in Alzheimer's disease, I started with the symptomatic, now I'm on disease-modifying. Disease-modifying treatment is where the future of Alzheimer's treatment is actually headed. So these treatments are designed not just to relieve symptoms, but to actually slow down the actual progression of the disease process itself. The aim of using a disease-modifying treatment in this case would be to delay cognitive decline and preserve function for longer. So while most of these therapies are still emerging, a few have already actually been approved in limited settings, and this signals a major shift in how we may be treating Alzheimer's in a few years to come. There is also what they refer to as the regenerative approach. So when we talk about regenerative treatment, we are more or less in a sci-fi scenario, no? Because we are talking really about the most ambitious frontier of care. This approach aims to replace or repair damaged neurons and, rebuild broken brain networks. And the truth is, as of now, this is mostly theoretical. No regenerative therapy has yet been proven to be successful in routine clinical practice. So if someone comes to you and they are selling to you drugs which they claim are going to regenerate your brain cells, please be wary of what they are saying. We have not yet reached there. When we talk about managing Alzheimer's disease today, something comes to mind. That is, as doctors, as clinicians, we like being seen as heroes. We like doing things and hope that the patient will go out there and say, man, that doctor is not easy. He's too good. Okay? Unfortunately, management of diseases such as Alzheimer's is never a one-person job. It is never a one-man's heroic act. So good care within the context of Alzheimer's starts with shared goals between the patient, the clinician, and the caregiver. And as the disease progresses, the treatment must keep changing because new needs keep emerging over time in the patient. Symptoms also look different. You'll not have two patients of Alzheimer's presenting the same way. They'll have different symptoms, different challenges. They'll be affected differently in different cognitive spheres. So care can never be a one-size-fits-all. On top of that, many patients develop other medical conditions along the way that also need attention. And that is why Alzheimer's care rests on three pillars, ladies and gentlemen. That is the medications, the psychosocial support, and strong, consistent care giving. So let us delve into the pharmacological treatment of Alzheimer's disease. Alzheimer's disease is a progressive condition, so cognitive decline and functional loss will naturally worsen with time. So the goal of symptomatic treatment is not to cure the disease, but it is actually to shift the curve, to slow down the decline of the disease, to improve cognition and daily function in the short term, and to help the patients to remain in the milder stages of the disease for a longer period of time. Now, when you come and look at this graph, the untreated curve shows a steady downward slope with symptoms which are worsening over time. But coming down here with successful treatment, you realize that the decline becomes slower. It is not as steep as this. It becomes a bit slower, more gentle, and more gradual. So the biggest benefit is seen when treatment starts early. I'll repeat this. The biggest benefit in the context of Alzheimer's, okay, is evidenced when treatment starts early. However, at advanced stages, treated and untreated curves may actually, not even may, they begin to converge, meaning that current treatments do not prolong life, okay? So if we are treating you for Alzheimer's, we are not saying you are not going to die or you are going to live much longer. Not really, not per se. We are saying we are going to slow down the process of you deteriorating. We are going to improve the quality of life you have. We are going to improve the quality of life in the years you have left to enable you to live with dignity and for you to function along the way. So at present, these treatments have not been shown to prolong life. And in later stages of the disease, the treated and untreated actually will be the same. So we need to take note of that. So much of the cognitive and behavioral decline we see in Alzheimer's is driven by gradual failure of the cholinergic system. Acetylcholine, as we know it, is one of the brain's key neurotransmitters for memory, for attention, and learning. In the context of Alzheimer's disease, the neurons that produce acetylcholine progressively degenerate. And so levels of acetylcholine are going to steadily fall over time. This loss is closely linked to the cognitive deficits that we are going to observe at the bedside. The forgetfulness, you are not learning new things easily, and so on and so forth. And so, ladies and gentlemen, this is where cholinesterase inhibitors come in. That these drugs block enzymes that normally are supposed to break down acetylcholine. In normal circumstances, when the cells are signaling to each other, acetylcholine is going to be released from the presynaptic neuron into the into the synapse, and eventually it is going to come to the postsynaptic neuron to do what it is supposed to do. After a short time, this acetylcholine is supposed to be broken down. But since we are already having little acetylcholine being produced in the context of Alzheimer's, we want it to stay here for as long as possible. So that is what acetylcholinesterase inhibitors do. They interfere with the enzymes or block the enzymes that are supposed to break down this acetylcholine, and so it will be able to act for a longer period, enhance cholinergic transmission over the course of the time the medicine is working. And the main FDA approved agents that we use in mild to severe Alzheimer's disease are drugs that we have heard of, such as donepezil, rivastigmine, and galantamine. So clinically, these drugs improve cognition, daily function, and some behavioral symptoms. And their effects often start as short-term symptomatic gains over a few months, but many patients actually have been seen to achieve stabilization that can extend beyond a year. So in some cases, meaningful benefit has been observed in patients who are using these drugs in up to 3 years. A disclaimer: these drugs do not cure Alzheimer's disease, but they are the backbone of symptomatic management of cognitive deficits because they are directly targeting one of the core neurochemical benefits, and that is deficits. That is the deficit of acetylcholine. So in the brain, the main excitatory neurotransmitter that we have is glutamate. And while it is essential for learning and memory, too much of glutamate is actually harmful to the brain. In Alzheimer's disease, it has been found that there is overstimulation of NMDA receptors by glutamate, and this leads to what we refer to as glutamate excitotoxicity, where a lot of calcium is going to flood into neurons and gradually damage them. So this process directly contributes to neurodegeneration and cognitive decline over time. And this is where the drug I talked about yesterday, memantine, this is where memantine comes in. That memantine is an NMDA receptor antagonist. So it works by dampening this pathological glutamate overactivity while still allowing normal physiological signaling to do what? To continue. So in simple terms, memantine is going to act like a protective filter. It is blocking toxic stimulation, but without shutting down the entire system. Memantine was first approved in Europe in about 2002 and later by the FDA in 2003, and it is used for moderate to severe Alzheimer's disease. It can either be used alone or in combination with cholinesterase inhibitors such as donepezil. So clinically, memantine has been shown to reduce overall clinical deterioration in moderate to severe disease. And it has also been found to help to improve thinking, daily functioning, and most importantly, behavioral symptoms such as agitation, aggression, irritability, and appetite disturbances. So we need to take note of that. Whenever we are talking about treatment, we need to talk about goals. So when we talk about the goals of disease-modifying treatments in Alzheimer's, we are no longer just talking about easing symptoms. We have moved past the level of donepezil and memantine. We are now talking about trying to change the course of the illness itself. So if you look at this diagram, if a person is untreated, this is how they are going to deteriorate over time. Okay? Excuse me. So a disease modifying therapy has one aim. That is to try and flatten this curve from it having this gradient to moving to this. That is, we are trying to almost halt progression. But most times what we end up achieving is slowing of disease progression in this case, and which is very important. We are allowing someone more time to live a quality life. So I have been saying currently we have no cure for Alzheimer's disease. So the moment you decline to this point, ladies and gentlemen, we have no drug that can drive you upwards for you to go back to the cognitive state you had before the disease had started. So it is very important to be honest about expectations when we are giving patients these drugs. These treatments are not expected to restore function back to pre-disease levels. The goal is to preserve what remains for as long as possible. And that is why symptomatic therapies still remain essential alongside these treatments. So as of 2023, we have 2 FDA-approved disease-modifying therapies. The first one is aducanumab, and the second one is lecanemab. Both of these drugs are monoclonal antibodies, and they target amyloid beta. Friends, remember yesterday I said that most of the theories explaining Alzheimer's suggest that the disease process starts with the deposition of abnormal amyloid beta around cells. And so aducanumab is directly addressing that challenge. But I don't want to pour out on you. Aducanumab, when it first came out as a drug, a 1-year dose, that is initiation dose and maintenance dose for 1 year, was about 56,000 US dollars. Currently, Biogen, that is the pharmaceutical company which produces it, reduced the cost, and it is currently about 26,500 US dollars. When you convert this to Ugandan shillings at a dollar rate of about 3,650, you end up with about 101 million shillings per year if you are to use aducanumab. So you realize that some of these medications, yes, are there, but are not within the reach of most of us. I am 100% sure that not even our senior consultants in this country can easily handle buying a drug that costs 101 million shillings per year. So it is still challenging, but we hope over time it will become cheaper. Now, when you look at Alzheimer's drug research today, one thing is clear. That is that this field is very busy and active, and it is evolving fast. Okay, a lot of disease-modifying treatments are being tested, and they are aiming at different parts of the disease process. Some are aiming at, ensuring that amyloid and tau are destroyed. Some are aiming at reducing inflammation in the brain. Some are aiming at synaptic repair, brain protection, to name but a few. So if you study the chart we are seeing here, you will notice that most of these treatments are currently in phase 1 and phase 2. So that reminds us that discovery is still very much in progress. Most of the disease-modifying treatments we currently have for Alzheimer's are targeting one key process, and that is amyloid beta accumulation, as I've earlier said. The goal is to reduce amyloid generation, to enhance its treatment, and to block its toxic effects on the brain. So that is what the likes of aducanumab and lecanemab are doing. They are both monoclonal antibodies, but which are designed to bind to amyloid plaques and promote its the removal of these plaques from the brain. Imaging studies that have been carried out among people who are on these drugs have actually showed that these the concentration of these plaques in the brains of these people who are on treatment actually reduce over time. Let us go to an important element of managing people with Alzheimer's, and that is management of behavioral and psychological symptoms. So beyond medications, there are a few general principles that quietly determine Alzheimer's care and whether it will truly succeed. Ladies and gentlemen, patients need regular follow-up. And it is not just to track memory and function, but also to monitor safety issues such as agitation, aggression, depression, and suicide risk. These risks evolve as the disease progresses over time. Let us talk about issues such as driving. Driving is yet another difficult yet necessary conversation, unfortunately, in the context of Alzheimer's. That as one's cognition declines, the risk of road accidents is bound to rise. And so patients with Alzheimer's must be clearly advised when it is no longer safe to drive. Education in these patients is not just the patients, actually, patients and caregivers. Education of these entities is just as critical as the treatment you give. I can dare say that the success of your treatment is hinged on how successful you are in educating the patients and caregivers. So patients and the families or caregivers need to understand the illness, the available treatments, and where to find support. At the same time, families need to be guided early about important things such as finances and legal planning. This patient is going to reach a point where they cannot make sensible financial decisions. The old man, the old woman will be tricked to sign an agreement where he is being paid 200,000 shillings to sell 30 acres of land. And so you need to have this as part of the education you are giving these people. Loss of capacity in Alzheimer's is a natural cause of the disease. And finally, none of this works without a strong therapeutic relationship. The trust between the clinician, the patient, and the family is the foundation that holds long-term Alzheimer's care together. We have a number of neuropsychiatric symptoms in Alzheimer's. Neuropsychiatric symptoms are not side stories in Alzheimer's disease. They are actually a part of the core experience for almost every patient. In fact, nearly all patients will develop these neuropsychiatric symptoms at some point, and they change a lot in the life of the patient and in the life of the caregiver. They are going to increase suffering. They are going to speed up cognitive decline. They are going to exhaust the caregivers, and they are going to often push the families in societies where they have homes where they can take care of these people. Families may end up sending this person to such a place, unfortunately. Depression has been noted to be one of the earliest and most common of these symptoms. Okay, still have time. Is one of the earliest and most common of these symptoms. And it can start as early as mild cognitive impairment stage. And it often signals a higher risk of progression to dementia. So this is something very important for us to note. But the diagnosis of depression in the context of Alzheimer's disease is unfortunately not always straightforward. But the treatment still matters. So we usually begin with selective serotonin reuptake inhibitors. And the rule of thumb is start low rather, and go slow with these people. Let us move to the next one, agitation. Agitation is yet another very powerful driver of distress, not in just the patient, but even in the caregiver. It may show up as pacing, shouting, restlessness, or even outright aggression. And antipsychotics can help in selected cases. Okay. So there are a number of guidelines. You can talk of NICE, APA, World Federation of Biological Psychiatry, to name but a few. But they have one non-negotiable rule. Ladies and gentlemen, drugs are never the first line for management of aggression in Alzheimer's. I'll repeat this. Drugs are never the first line for aggression treatment in Alzheimer's disease. Always first exclude issues such as pain, infections, constipation or urinary retention, delirium, environmental triggers, sensory overload, sleep disruption. Okay? And medication in this case will only be justified when the aggression is severe, persistent, and dangerous, or when there is imminent risk to the patient and the caregivers. If we are to walk away with something, let us take that. If we are talking about drugs that you can give, the first line, usually that is evidence-based treatment, has mostly been risperidone, which we can start with 0.25 to 1 milligram. Okay. We can also think of olanzapine, which can start as low as 2.5 to 5 milligrams, quetiapine, which can start at 12.5 to 50 milligrams. Quetiapine is wonderful, especially if these patients are having sleep disturbances, which I'm going to talk about. But all antipsychotics, unfortunately, carry a warning. That is the risk of increased mortality and stroke in the context of dementia. So they must be used at the lowest effective dose. Review the patient after every 4 to 12 weeks. And then once the behavior stabilizes, please taper off. Taper off. Some caretakers may feel like saying, well, I mean, this drug we are giving is giving us a bit of peace. Let us keep him on it for a year. Please never do that. There are drugs that should be avoided or used with extreme caution. Drugs we have in our setting, haloperidol, only use it for emergency sedation. And that is because it has a high risk of extrapyramidal side effects, rigidity, aspiration, and mortality. Avoid benzodiazepines if possible. The reason is because they worsen confusion, they increase the risk of falls, and they may cause paradoxical agitation in these patients. Now, talking about sleep disturbance, it is actually very common. And once sleep breaks down, we know that everything worsens. The memory suffers, behavior worsens, and caregivers are bound to burn out faster. You are sleeping at 1 a.m. and you hear someone waking up and singing, or they are urinating in the sitting room. This is a lot of disturbance. So the truth is, if we manage these neuropsychiatric symptoms well, we will change how the disease is lived and not just how it is labeled. Now, when we talk about psychosocial therapies in Alzheimer's, the core goal is simple but powerful. It is to improve the quality of life and to help these patients to function as well as they possibly can. That is despite the cognitive challenges they're having. And these therapies are not just add-ons. They are not things you are supposed to think about as a by the way. They are very necessary because they are going to directly shape how this person will live with this illness every day. So over time, a number of psychosocial approaches have been developed. Some are aimed at the patient, others at the family, and many of them are aimed at both. Several have enough research support to actually be part of routine care. In practice, psychosocial interventions are delivered, can be daily, it can be weekly, and they should always be chosen based on what is available, what the patient can afford and what fits the patient's personality, their needs, and their preferences. And beyond what we can highlight here, even something as simple as regular moderate exercise, like walking, it has been shown actually to do what? To improve cognitive outcomes within these patients. So psychosocial therapies often fall into two broad groups. That is the behavior-oriented approaches and emotion-oriented approaches. Behavior-oriented treatments focus on one key goal. That is to identify the problem behaviors and reduce how often they happen. That is by changing the patient's environment. For example, scheduled toileting can actually reduce urinary incontinence, and training of caregivers can reduce aggressive behavior. Once you train these people on how to react to this person, it can help to reduce this aggressive behavior. If someone is coming, your dad is telling you, you realize you're an adult and you're also saying, Mosei, I am a grown man, I'll also beat you. You are going to put the house on fire. So if you are trained, you know what to expect and you respond better. And one practical framework that we usually use is called the DICE approach, where we describe the behavioral symptoms and the circumstances. We investigate the potential internal and external causes of this behavior. We create interventions, individualized solutions, and then we evaluate the outcome. We also have emotion-oriented approaches, which aim to address the emotional distress and improve mood and behavior of this patient. We have things such as reminiscence therapy, where you can use old photos you have had as a family, music, and stories to help this person to reconnect with their past and to feel more emotionally grounded. There are things such as validation therapy, where we stop arguing with their reality and instead validate their feelings. This helps them to calm down and to trust you, the caregiver. And certainly we have supportive psychotherapy within this. So together, these approaches remind us that not every symptom in Alzheimer's is managed with medication. So the two approaches we are seeing here are really about helping the brain of this person to stay active in practical, everyday ways. We have what we call stimulation-oriented therapies. And these ones use simple things people already enjoy. Things like music, art, games, crafts, pets, gentle exercise. These things that we take for granted actually wake up thinking and elevate or lift the mood of this patient. So when they are done regularly in groups, for example, they can improve both cognition and the emotional well-being of this person. And this is most especially in mild and moderate dementia. Then we have cognition-oriented approaches. These ones are a bit more structured and they are skill-focused. So through activities such as reality orientation and cognitive retraining, we work directly on the memory, the attention, and everyday thinking skills. And the gains may be modest, but we know that one by one makes a bundle. So these interventions together certainly help the patient a lot. So when managing Alzheimer's, we often think about medicines and therapies, but caregiving is very important. In fact, ladies and gentlemen, Alzheimer's care rests on three pillars working together. That is pharmacological treatment, psychosocial support, and caregiving. Without caregiving, the other two can never succeed. So as the disease progresses, the amount of time and energy required to care for a person with dementia becomes more significant. The person becomes more dependent. The patients become, develop a lot of symptoms, aggression, agitation, and so on. And all this is draining the caregiver. And that is why caregiver support in the context of Alzheimer's is not optional. Research shows that caregivers who receive psychoeducation and structural support are better able to help these patients with Alzheimer's disease. So whenever we are dealing with this, we need to come up with interventions such as giving even caregivers a break. If I have been looking after my mother for 3 months, 4 months, please get my sister, get someone else to come and take over a bit to allow me to breathe and re-energize. Okay. So Alzheimer's disease is progressive. So a person's symptoms will naturally change. And because of this, treatment should never be fixed. It must be adjusted to match the stage of the disease, whether mild, moderate, or severe. And medications for cognition are chosen based on the stage in which that person is. And the interventions should always be guided by the patient's individual needs. That is very important to note. So in mild Alzheimer's, emotional support is very important. Depression, we have said, is common at this stage. So regular counseling and simple psychosocial support can make a huge difference. Things such as practical memory aids help these patients a lot. You know, things like diaries, reminder notes, recording devices can help these people to be supported. Okay? Patients can benefit a lot from emotion-driven therapies such as supportive psychotherapy and the other therapies that I talked about. So from a medical perspective, a trial of cholinesterase inhibitors is recommended in the mild stage. In the moderate stage, safety and supervision becomes a central part here. Many patients can no longer be left alone, even for short periods of time, because of risks related to wandering, poor judgment, and unsafe behavior. At the same time, the burden on caregivers is increasing a lot, and so respite care is necessary, whether through family, home help, or daycare. The caregivers need some breathing space. So at this stage, that is moderate, we can combine a cholinesterase inhibitor with an NMDA receptor antagonist. So you can give donepezil with memantine. You can give galantamine with memantine, together with the other interventions that we have talked about. In severe Alzheimer's, patients are often fully dependent on others for even the most basic things. Someone can't dress himself, can't bathe, feeding, moving around, and so on and so forth. So at this stage, it is very difficult to actually diagnose depression, and that is because this person may not be able to communicate what they are feeling. So many of these patients eventually need a transfer to either a nursing facility or some other place where there is specialized care. From a medical perspective, memantine is commonly used at this stage to support cognition and behavior, but other medications may be added if psychotic symptoms or dangerous agitation appears. So, as we are concluding, Alzheimer's is never managed with just one tool. It requires a careful balance of pharmacological treatment, psychosocial support, and caregiving, all of these working together. When one of these is missing, the care becomes incomplete. From the medical side, the main drug treatments we rely on, as I've already said, are cholinesterase inhibitors and NMDA receptor antagonists. So I'm not going to talk about aducanumab because very few Ugandans can manage that drug. But all the same, it was good to know about it because some of you may work in the US, in Europe, and so on and so forth. So it's important. Equally important are psychosocial therapies, which I have already talked about. And I insisted on the importance of caregiving because these people depend a lot on caregivers. Ladies and gentlemen, I thank you so much for having listened to me. Allow me to hand the mic over to Dr. Katama. Thank you.
Wow, 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 wow. Thank you very much, Dr. Muyanga, for such a wonderful educational presentation. You always make these things appear so easy and obvious, not until someone either is in an exam or is having to manage a patient, and then you realize that, yeah, they can be quite tricky at times, but you have really done a great job in simplifying this whole complex thing. As we've all had, the things are really not that straightforward as some people think, that maybe just after you diagnose, you say now the treatment is this, you give and they go home. There is a lot to do following the biopsychosocial model. Biologically, we talked about the medications and then the psychosocial interventions, then focusing on the caregivers. Thank you very much, Dr. Muyanga, for giving us this insightful presentation. I would request Dr. Mwanguzi to post the poll at this moment so that we can get responses to it as Dr. Muyanga responds to some of the questions that are within the chat. Please respond to that poll so that we can see if at all whatever we've been doing this week has had an impact. So going on to the chat, just a few comments here and there. And I'll start with Tony Kugonza, who says, comment on the use of cholinesterase inhibitors in the treatment of memory deficits in major depressive disorder. Dr. Muyanga, do you have something to say on this?
Thank you so much for that question. Cholinesterase, major depression has been referred to as a pseudodementia. And that is because it presents with cognitive deficits. But the cognitive deficits that we have in the context of depression are do not have the same biological roots as we have in Alzheimer's dementia, for example. I earlier explained that in Alzheimer's dementia, because of glutamate excitotoxicity and, the other neuropathological pathways that we talked about, there is destruction of cholinergic neurons, which is going to lead to a decrease in production of acetylcholine. And so cholinesterase inhibitors in this case would help in one key area, that is prevent the breakdown of acetylcholine so that it lasts longer and we have its benefits. We are not having this happening in the context of depression. And so even if you went ahead and gave this patient donepezil, you are addressing the wrong challenge. The challenge we are having in depression is to do with a totally different set of neurotransmitters. We are talking about serotonin and the other related neurotransmitters. And so we are supposed to address that directly. So we are not going to give donepezil in the context of major depression, ladies and gentlemen. We shall give antidepressants together with the other psychological interventions that we know about. Thank you.
Yes, thank you, Dr. Muyanga. I hope that answers your question, Tony. Yes, in major depression, basically, we are looking at the other neurotransmitter systems, the serotonin, epinephrine. We looked at this, and if you didn't catch this, you can go to our YouTube, and then you're going to find the very first presentations we had. We covered depression. So there will be no role of cholinesterase inhibitors in that regard because the pathways are different, as Dr. said. Thank you, Dr. Muyanga, for that response. Then Dr. Muse Muhammad comes back thanking the Uganda Moratorium organizing team and the presenter, Dr. Muyanga, for guiding us through this excellent program. And as today marks the final training, he acknowledges the significant, he appreciates the significant knowledge that has been gained, and he truly hopes for other sessions in the future. His question says, thank you, Dr. Muse Muhammad, for this message. It is really good to us. And yes, we shall come back with more exciting sessions. So his question is that how can formal communication strategies, such as the structured cognitive interventions, caregiver training programs, be effectively integrated with the non-formal communication approaches, like the personalized routines, the environmental cues, and behavioral redirection that you talked about, to optimize patient engagement and maintain functional abilities in individuals living with Alzheimer's disease. Dr. Muyanga.
Thank you once again, Dr. Mose. It's always a pleasure to have you in these chats. I also recognize the presence of other seniors within the chat, Dr. Eric Iriza and other seniors who are here. So the secret to good communication in Alzheimer's, this laptop wants to go for this time. Just a minute. So the secret to good communication in the context of Alzheimer's care is blending structure with everyday life. So formal strategies like cognitive exercises, which I have talked about, and caregiver training actually give a strong backbone to this. They teach caregivers how to speak calmly, okay? Guide this person gently. They are not the person they once were, okay? Respond to this person in a steady way. But what truly carries the patient through the day are actually the non-formal approaches, simple routines, familiar surroundings, clear signs. If it is a toilet, yes, for us normal people, we know. I don't need you to put a pointer for me that is where the toilet is. But for this person who has memory issues, please put that sign, clearly label the door that this is the toilet. If you don't do that, don't blame that person when he goes and urinates in the sitting room at some point in time, okay? Issues such as gentle redirection instead of arguing with this person, okay? So when these two work together, the patient is bound to feel safe. He will not be so confused, okay? They will also be able to stay more engaged because their life feels a lot more predictable. I mean, when I feel like urinating, I don't need to think a lot. I can just turn around and I see arrows pointing me, showing me the toilet is located that side, okay? And ultimately, it will help them to have a better life. So the secret is about consistency, kindness to these people and helping them to feel guided, but not controlled. The moment you start trying to control these people, everything is bound to spiral out of control. Thank you.
Yes, Dr. Musa Muhammad, I hope that answers your question. I remind everyone to respond to the poll. In case it has disappeared from your screen, if you scroll down, there is some icon where you see three dots, and when you click on it, you're going to see polls and stock quizzes. You click on that, and then you'll be able to access the poll yet again. Please respond to this poll. It is really necessary that we capture your responses to this poll. Yes, so continuing, Anita Marambo says the training has really been insightful and this person has learned a lot. says should consider some topics on pediatric psychiatry as well on the next training. So in Uganda, under the moratorium educational grants, 2 grants were awarded at the end of last year. And the one was this one that we are looking at, the moratorium peer-led training to enhance neuroscience knowledge in the psychiatrist and trainees. But then there was another that was awarded that dealt with child and adolescent psychiatry, headed by Professor Abo. So more information on this shall be coming up, since we know the email contacts of everyone. We shall be sharing on how to integrate some of these things. People really appreciate the work you've done, Dr. Muyanga, the efforts, the good delivery, and we really thank everyone for this whole period that you've been with us. Sarah Nasozi says also we need the same program for child and adolescent psychiatry. I think I have responded. To this. Please respond to the poll. I remind us again that we respond to the poll. Right now, I want to share something small so that it gives us a picture in a minute or two about what has happened in the past. So this has been, So these have been our numbers in terms of attendance of participants from day one, week 1. So we had 3 days in each week, and you see that on day 1, we always have a high number, then drop off, day 2, then of course day 3. Which makes us a bit worried, of course, based on this drop, these lower numbers on the 3rd day. And yet on the 3rd day, that's when we are dealing with the management principles of these conditions. So in week 1, we looked at depression, and then in week 2, we looked at substance use disorders. Then in week 3, we looked at schizophrenia. Week 4, we looked at bipolar affective disorder. And then in week 5, I went ahead and looked at anxiety disorders. In week 6, we looked at Parkinson's disease. And then in week 7, we have looked at Alzheimer's disease. This series will come back next year, of course, and we shall be glad to share with you more of the knowledge that shall be coming up. We always remind you to sign up to the Moratorium website. You sign up for the newsletter so that you can receive updates of whatever is happening in the world of neuroscience from Moratorium. At this moment, I would like to invite Dr. Muyanga to close this series, since he's the principal investigator on this project. Dr. Muyanga, you're welcome.
Okay, thank you, Dr. Katama. I think my job is to thank everyone. But before I do that, I would like Dr. Mwanguzi and Dr. Nawiri to unmute themselves and say something. The fact that this series have run on time, there have not been people logging in, no background noise, is down to these 2 brilliant people. And I don't think we should close without at least them being recognized. So Dr. Nawiri, Dr. Muyanga, I would want people to see you. In case people have programs they want to run, it would be good for them to know who you are. And you see, or say something. They've been in the background too long. So.
Yes, thank you very much, Dr. Muyanga. for recognizing us. Personally, I'm just very grateful to the participants. Thank you for persisting all through these weeks to attend these sessions. It wouldn't really make sense if we organized them and then no one turns up to actually attend. So very, very thankful for the participants that have kept logging in, especially those who have been very recurring. And considering the time is not like work time, but you have actually been sparing the time either way. Thank you so much. And to the presenters, well done. You have done tremendously well, and we really appreciate you. Thank you for sharing your knowledge with us. And Dr. Mwesiga, thank you for giving us the opportunity to learn while working and on this program. It has been 7 weeks in total, today marking the very last day, with a total of 21 sessions, because I've been holding 3 sessions each week. That is 3 days each week. And we would like to share with you some statistics, more like figures of how the numbers have been over the weeks. And Dr. Mwangus will be doing that. Hopefully he's ready. So in the interest of time, let me hand over to Dr. Mwanguzi to share with us some statistics. Thank you.
Yes, thank you. Thank you so much, Dr. Lillian, and good evening, everyone. I'm also adding on what Dr. Lillian has said, and our PI, Dr. Mwesiga, thanks for attending these sessions. It's been 21 weeks of daily sessions. Those are 3 days in a week. And really thank you for showing up. So we have had a varying different participants from different areas, social countries. So we have had the majority of participants from Africa, mostly from Kenya, from Uganda, of course. We have had some from Tanzania, some from Rwanda. We have had majority of participants coming from Uganda, but we are really appreciative of those who have been joining us from different countries. We have had some from even beyond Africa, some from the US, some from the UK, the ones who are part of this forum where we have been sharing the links, and we are really, really grateful for showing up and attending these sessions. I can't thank enough our facilitators, Dr. Muyanga, Dr. Sadat, Dr. Kemirembe, Dr. Raymond. We are really grateful for the time you have invested in compiling up all these slides. Some of us who have visited the Moratorium platform, we recognize that the slides are really enriched, but we recognize that when the trainers bring the simplified versions, they are palatable and better simulated, and they give us a very good background to go and look at the details from the slides on the platform. So we are thankful. Dr. Lillian, I think Dr. Katama had already shared that the attendance, the trend over the 7 weeks, but broadly, we have had attendance not going below 200, roughly between 200 to 400. Of course, during the last 3 weeks, 5, 6, 7, we have had a reduction in attendance, which is really understandable because participants, most of them are students and exams have already started. But we're really grateful for those who have even kept attending while in exams. I'm seeing many of my colleagues I know who have done papers today, but they've managed to log in. That's really commendable. And lastly, I would like to thank our PI, Dr. Mwesiga. We are grateful for giving us the task to organize the sessions. I think it's been a very great team, cohesive, working together to galvanize the entire process to the success we are seeing today. Thank you so much for guiding us. I think your green light has taken the lead in organizing all these sessions. We cannot say that we've done this on our own, but your guidance has been really instrumental, and I'm really thankful. Otherwise, I'm really looking forward for the next sessions. I'm sure this is not the end, and we shall be getting back to our participants when we get another opportunity. Thank you so much.
Right. Thank you, Dr. Mwanguzi, and thank you, everyone. Just Naiga is asking whether we shall get attendance certificates if I've been persistent for these 7 weeks. Well, what I can say is, since we are coming up with more of these sessions, I believe that in the next, yes, Dr. Mwesiga, please go ahead.
Sorry, I just wanted to say, again, I don't want to say that I have driven this a lot. I'd like to thank the presenters and the people in the background. This is our first year of 3. Over the next 2 years, we will take the data we have used here and change it a bit and improve the session. Maybe make some sessions specifically for certain groups or for certain topics. It will depend on what the data says. But thank you very much for these 7 weeks. I've actually also learned a lot. And may God bless you and keep you well, and happy holidays. Thank you.
Thank you very much. I'd like to thank everyone who has been with us through these 7 weeks and invite us all to the next sessions when they come up. Of course, these will still continue for the next 2 years based on the grantor. And also, Merry Christmas, as Dr. says, in advance, because, this is the last that I can have to say this to all of us. Thank you everyone for attending. We have shot by around 7-8 minutes. I wish you a wonderful night.